Welcome everybody for next part of our Ocular Insider podcast. I'm Peter Baranovic from ESW Vision, and I'm having today in academia in UAE, in Dubai, during the nice show about the dry eye symposia. One of the most famous Egyptian doctor, Dr. Ahmed Assaf from Egypt. So tell you a little bit about him during his 25 interesting career and achieving one of the pioneering phaco doctors in Egypt, and also Lasik cataract refractive surgeon, professor in university, having the private practice, teaching and leading a lot of the new ophthalmology doctors in Egypt. Also member of ESRS, ASRS, the American Academy of Ophthalmology, and also board member of Egyptian Ophthalmology Society, and now also Dry Eye Society, just having a nice conference in Egypt. So tell us, Dr. Assaf, what is driving you through your ophthalmic career and that brings you to the point of becoming a dry eye leader in this society?
The most driving force is the passion about your profession. So you have to love your profession, and then once you like or love what you are doing, then you will definitely excel in your career, and you will getting the best for yourself and of course for our patients. So every time we have a quest to look for the best for our patients in terms of the cataract and refractive surgery, and of course the dry eye is pretty much related to those fields in ophthalmology. So I do recommend that we have to love what we are doing in our career, and love what we are doing for our patients.
Oh, that's definitely I agree. So what is for you the key steps? When you I see your private practice in Cairo. Thanks for this experience. It's lovely, and I see your passionate staff and hundreds of patients waiting for your most precious time. So what is the standard procedures when you're doing with your refractive patients? Or I'm not gonna jump directly to the dry eye patients. What is your steps, for example, in your practice for your refractive patients?
Yeah, thanks, Peter. This is a very good question, because I taught my staff that there are some standard procedures should be done before the patient stepped inside my office. For example, for every patient coming from for cataract surgery, we have to do the corneal tomography, dry eye, objective dry eye measurement.
Okay.
And of course, the assistant doctor examined the patient thoroughly for dry eye and for anterior segment as well as posterior segment. And if necessary, we have to dilate the patient and look to have a look on the back of the eye for some posterior segment pathology. This is before the patient steps inside my room. So we have corneal tomography, dry eye measurement, as well as anterior segment OCT. And then we have all the data. Once the patient steps inside my room, I have all the data collecting in front of me with the screens, so I can have an idea about the corneal status. I have an idea about the dry eye status for the patient, and I have an idea about the anterior segment status, and sometimes the patient was already dilated, so I can get an idea about the periphery of the retina, and then we can discuss the surgical options for the refractive patients, for the correct the refractive error. So what I do like in my office, the dry eye diagnostics. So we have not only just subjective, maybe of course this patient, you have to take a history from the patient, or just taking the history from the patient. I want to have an idea about the lifestyle of the patient, not about the screen time of the patient, which is used to be pretty long most of the times. And of course, I have to do some objective tests, like the staining by lissamine green, and do some staining by fluorescein stain on the ocular surface. And of course, I have to look for the tear meniscus heights on the right lamp. And have the patient already done the objective measurements by tear film analysis, so I get an idea about the meniscus heights objectively measured by the tear film analysis with some fancy device we have. And the most important that I do like is mammography.
Oh yeah.
Mammography gives a direct clue on the status of the dry eye of the patient, which is pretty common. So I get an idea about the status of the meibomian gland. I have direct access to the status of the meibomian gland to see some pathological changes of the meibomian gland, like truncation, dropouts, acinar changes. Then we can discuss the options for the patients based on the dry eye, because the dry eye is pretty much related to refractive surgery, as I mentioned, and sometimes I have to change the strategy for treatment the patient based on the dry eye. So sometimes I have to go for maybe lens-based refractive surgery, not the laser-based refractive surgery, because of the dry eye. Sometimes I have to reschedule another visit for the patient until I have to treat the dry eye before scheduling the surgical procedure for the patient. So dry eye has a pretty much a huge impact on the decision making in cases of refractive surgery.
So I see a little bit of your clinic, how it's running. How big important part you thinking in a patient education, like to educate him about his problems and different modalities in the treatment. Do you see the difference in the time you're spending with the patient in the beginning, or if you just want to make it shortly and then a little bit longer? What it makes more sense, to explain the patient all, or just to go very roughly?
No, we have to explain the patient everything. And we did a huge campaign on TV and social media about the dry eye awareness for the patients coming for refractive surgery. So, and now in the meantime, I used to have a very, I like this comment from the patients. Sometimes the patient just sit in front of me for street lamp examination, and the patient asks me, "Doctor, do I have a dry eye?" So I like this question. I like pretty much this question, because now the patient is aware of the dry eye, and this dry eye should be addressed before taking any another further step for treating the refractive surgery. So patient education is a must. We have to educate our patients before stepping inside the office. And once the patient sits in front of me, I have to explain everything related to the dry eye, as well as the refractive solutions available for this patient.
Okay, so when we're talking about this, once you have a finding, yes, you suffer, not suffer, symptomatic, asymptomatic, what are your modalities for a treatment before you enter to the refractive surgery?
It's based on each case. It should be individualized. I don't have the standard procedure for each patient. So, for example, mild dry eye, we can just reschedule another examination for the patient and just put the patient on dry eye drops, because some patients, they don't put any eye lubricants on their eyes. So maybe I will just tell the patient, okay, you can put these eye drops 5 times per day for 1 week or so, and then come back again for another reassessment. Or sometimes I have to be more aggressive to prescribe some anti-inflammatory eye drops, maybe a short term of topical steroids, or in many cases I have to reschedule intense pulse regulated therapy for the patients. My protocol in these cases, severe dry eye, is that I do sometimes the 3 sessions.
Okay.
Or maybe I can do 1 session and then the refractive procedure, and then another 2 sessions later on, sometimes the 3rd one as well.
You see a good tolerance? Yeah, it's even you try like to have a 1 day, same time, the IRPL and then refractive, or you wait?
No, I do the intense regulated pulse light and then wait for 1 or 2 weeks. And I see that the patient subjectively improved and I objectively as well improved. Then I will do the surgical procedure and do another 2 sessions of the intense regulated pulse light.
Have you noticed any like improvement in ocular pain after the surgery that we having before and also after and now? After the improving with the IRPL, for example?
Yes, that's why we're still running this intense regulated pulse light, because if we don't have any positive feedback from our patients, we will stop using this device. So I can guarantee 90% of our patients are pretty happy, and I have done this intense regulated pulse light maybe for 3 years or more, and we receive every day many patients that we have already did intense regulated pulse light in the past. They are coming for asking for another session.
Okay.
We educated our patient that we need a regular maintenance.
Have a positive feedback.
Yes, that's why they are coming by themselves, asking, okay, I have some symptoms of dry eye. So am I a good candidate for another sessions of intense regulated pulse light? And we used to educate our patient that, okay, we can give you 3 or 4 sessions, and then it's preferable to do one session every 6 months.
Okay.
So the patient understand this because the patient feel the difference after the treatment, and feel that the amount of or the frequency of the blurry vision and the frequency of burning sensation or grittiness they feel, it's much less compared to the before the intense regulated pulse light. And that's why they are coming by themselves asking for another session.
As you are coming from Egypt, and I love Egypt because of the lot of history and the nice people, and of course it's our frequent holiday destination. Did you see during these last, let's say, 5, 10, 15 years, a changes in a population of being impacted by the dry eye? I know that heavy use of computers are running, but how is the situation in Egypt right now?
Yes, thank you again for this excellent question. We used to see dry eye even in pediatric age group. In 9 years old, it's pretty much frequent to see a child that is coming with the symptoms and signs of dry eye, and the child is only 9 years old or 8 years old because of the screen time, because of the online schooling, and because of the digital learning. And this have been escalating up after the corona times, after the COVID-19. So we used to experience pretty much frequent dry eye patients in all age group. It's not necessary to be in adolescents, but sometimes we find it in children as well. And the frequency of dry eye patients, I can guarantee that around maybe 9 out of 10, every patient coming inside the for ophthalmic examination is the patient having some degree of dry eye, mild to moderate, sometimes severe dry eye, and the patient has been misdiagnosed before as an allergic eye disease, not dry eye.
Yeah, I see this a very also during the patient understanding, and I also see when we diagnose the even people here in this nice event having a little bit different expectations for their dry eye, and of course related to the skin diseases, rosacea, different reasons for inflammation in ocular surface. How you see the educational part during the population? Do you see any improvement? I know that you are very actively acting in Egypt, being television, trying to educate the people, being in school. Do you feel that the new generation of the doctors may have a chance to change this situation?
I think that yes, they will be obliged to change their regimen because now the patient awareness of the dry eye. So in the very beginning, we used to have some resistance from our patients to do the tear film analysis before the refractive surgery. I'm coming for Lasik. Why I'm doing too many tests? I know that there is only pentacam or Scheimpflug imaging, and that's it. So we can decide I'm good candidate for Lasik or not. But now the patient is aware that there is a dry eye and we have to do a particular test for dry eye and another test like the anterior segment OCT to endorse the findings that we might find on the Scheimpflug imaging. And so the patient comes, okay, we have to do at least 3 tests, and the patient, and there is no negotiation. The patient understands this pretty well, do the investigations, and waiting for the results from the doctor. So I think now because of the patient awareness, this wave might change the practice in Egypt. Other colleagues will have more detailed insights about the dry eye, and they will incorporate the dry eye diagnostic treatment strategies for their patients as well. Because now the patients are asking about their dry eye status.
Okay, that's definitely, I think, the one of the positive side of your work and also work of your colleagues. When I see in your clinic the setup of this dry eye spa or that dry eye suite, how would you describe the best setup? Number of doctors responsible, the staff that you think that they can do. What is your secret? I know that you have an excellent doctor, Dr. Hamsi, that she's helping you in your clinic. What do you think is important for a clinic size for refractive center to build up to reach this level?
I think it's better to dedicate one doctor for the dry eye management. So this doctor will be acquainted with the in-depth about the science of dry eye, because there is a science related to dry eye. It's not a dry eye that like the evaporative eye dry disease or meibomian gland dysfunction or whatever. No, there is a science behind this disease, and there is a different line of management and different protocols. And I think if the patient, from the patient perspective, if the patient sees that we dedicated just one room for diagnostics and for treatment of dry eye, and one doctor assigned for this disease, I think the patient now is pretty much happy to this is the secret in my practice, that you have to dedicate someone to handle this practice.
Do you feel that in a future will come something much more progressive, or you are missing something that would needs to come as a new modality for the treatment, be able to treat patients even more effective? Because as I know, and I'm sure you will also agree with me, because dry eye is multifactorial and a lot of things playing the role. Do you believe that new technology or new steps would help us fix the problem much more, or it's because of global issue, it will be not that easy?
Both. Because of the global issue.
Sorry for a complicated question.
Yeah, both. But my answer is both, because of the global issue, it won't be that easy. But we, of course, science won't stop, and we expecting new technologies that emerge on the surface every now and then. So, for example, maybe 1 decade or more, we didn't have the intense pulse light.
Yeah.
Now we have the intense pulse light, and they have been transferred to intense regulated pulse light. And there are some other different modalities trying to melt the medium, like the LipiFlow or whatever. But now we have new technology that coming on the surface every now and then. So I believe that future is bright on basis of the technology for treatment of dry eye, on the basis of the awareness from the patient perspective of dry eye. And it won't be that easy, because we are living in the digital atmosphere everywhere, digital screens, the mobile phones, iPads, TVs, and so we have to live with that.
Great, thank you for answer, and I see that definitely dry eye will be with us for a long time. And thank you that we are much better prepared with you and the doctors like you that are helping us to build us awareness and also bring with the new ideas. So thank you so much, Dr. Assaf, be my guest today, and be part of our new podcast about the dry eye and ocular surface health. So thank you so much, and hope you enjoying the academia and also meetings with your colleagues here.
Thank you very much. And I would like to add one more comment, because I expected that the dry eye will be an issue. And I used to tell my colleagues, especially younger colleagues, this is the coming era. If you don't invest in the dry eye management, you will lose a lot. And I have been saying this for maybe 5 or 6 years back.
Yeah.
So I do not regret what I've invested in dry eye, because, for example, if you look back in the history of ophthalmology, or at least for the anterior segment surgery, we had extracapsular cataract surgery, and then we had an IOLs, and now shifted to phaco-emulsification, but the IOL technology was lacking behind this small incision phaco-emulsification. Now we have foldable IOLs, and now it's only not all IOLs, but just IOLs to correct the refractive issues. So we have Lasik, we have femtosmile, or lenticule extraction. I told them, okay, now we are going in the plateau for the refractive surgery. You have to look for the dry eye. Dry eye will be an issue. And I'm expecting a lot of different new technologies for treatment of dry eye. I was used to tell this maybe like 5 or 6 years back, or maybe more. So now we are here in 2025, and you can see many different modalities, new fantastic technologies trying to counteract, at least, let's say, not treat 100%, to counteract the effect of dry eye. And I'm sure if you invest in the dry eye management, you will gain more patients, better refractive results, and better reputation.
Great. I definitely more than agree with you. And I think that hopefully that you join our discussion today and you learn a little bit from your enormous experiences. And I'm looking forward to meet you next time, maybe to discuss a new modalities like you described. So, and thank you so much. And I would like to invite you also for our next sessions and on Optical Insider. And thank you so much, Dr. Assaf, again, for being today, Mike.
Thank you very much. Pleasure to be here. Thank you, Edinburgh. Thank you. Thank you.
Yeah, thank you. Bye.
Bye.